So Tuesday training for practitioners. Let's let everybody in. I'm so excited to see you guys. Joanna's autopilot. I feel like that's an AI thing, but I think it's also a real person. Hi, Joanna. Hi, Lori. Let's see. Hey, Anna. Nice to see you. Hey, Lena. I'm glad you're here. So nice to see you guys. Hi, happy Tuesday. I love this time of the week. It's one of my favorites. Hi, everybody. Tuesday training. Whoop, here we go.
Hi, Anna. Yay, Anna's back.
Yay, Anna's
Not
back.
just for a pop-in.
And
left my client in legs up the chair, up on the chair. Just let yourself out.
Fine. Oh my God, I love it.
I love that too. Oh my goodness. And I love actually, Anna, that you've been busy a couple weeks with clients and that's why you weren't here live. I mean, that's an okay thing. That's what we wanted after, at this line of what is it? This section of the track. I'm not a
I like it when you try to bring in sports stuff.
I was like, never a win.
Hey, Cheryl.
Hey, Cheryl, it's good to see you.
TSM for the win. TSM work for the win.
Yeah.
I love it.
Okay, Cheryl, you're going to love it. You're going to just love it.
Oh, wait, she's like,
she can't hear yet. Okay. Perry, I'm glad you're here. Shelly, welcome. So glad you guys are all here. Come on, camera, if you want to. No pressure. You're welcome to be here in the back.
There's Perry.
Perry,
again. Perry's back.
Yep. And if you're in a place where you can't come on camera, that's okay too. Totally fine. Connect with us though and use your chat. So if there's any questions you have, I can answer them for you. We're going in for an hour of functional movement. Whoop, whoop. Functional movement. Yeah. How many of you guys saw the live over the weekend? The impromptu. Anybody here? No. See, freaking algorithms. That's all right. That's okay. Live here and in person is better. I posted over the weekend. Some functional movement and neuroplasticity was on my mind. So I was like, all right, why don't we talk about that? So we're going to continue with that conversation today. You guys have the link in your email. If you guys are on the newsletter list, then you are on the email list. You got an email today about the training today, and that replay link is in there. But we're going to talk about that today. If you're joining us for the first time, welcome. We're so glad that you're here. We have a very fun, lively group that meets Tuesday, not obligatory, but committed and shows up every week, which is so awesome. And we're here to talk shop. We're here to talk client work, anatomy, physiology, some professional development when that comes in, because that's always, good for us to keep our pulse on. I'm your host for the hour. I'm Gina Schatz. I am both a manual and movement practitioner. I've been working with clients for 31 years now. That is a long time. And I have no intention of stopping. And along the way, I developed the Schatz method and now train other practitioners in that method too. And I think we get to give a little bit of love to our method today because there's been some questions. In fact, one of our summit guests, we have an annual summit every year. I know a lot of you know that. And one of our summit guests, I think it was last year, said, oh, everybody's got a method. And I was like, and it's true, actually, right? Like a lot of people are calling their stuff. It's part of their branding. And so it could be really mistakenly thought that the Schatz method is a branding a branded sort of phrase. But it's actually not. It's trademarked and licensed. And so the practitioners that come through the mastery program really go through a transformational process in that training track, and they learn how to work the same way I working with clients to alleviate chronic pain and to create therapeutic and corrective orthopedic solutions for clients who otherwise couldn't do what else they wanted to do with you before you got into the Schatz method. So it's not meant to be you have to come every week and be committed to the Schatz method work as a client. In fact, what I tell my clients is whatever issue you're having in your body, we should be able to solve it in 4 sessions. So if that sounds good to you, if you want to solve whatever the ailment is and get back to your life or get back to the other thing that I do with you, yoga, Pilates, massage, what have you, personal training, then let's just go over here and do this method thing and get that out of the way so we can go back to doing the other thing. And so it's really effective, which is the point. And I love working that way. And I love training other practitioners to work that way and get those wins as well. And a plug for the mastery program, because this is our annual window where Our graduates are about to graduate here in just a week and a half, and our new pod is coming in just a few weeks. I know it's happy, sad, Anna. It's happy, sad. I know.
It's super heartfelt right now. Yeah, there's all kinds of stuff going on.
A lot of emotion. I know, right? We get like super happy. We get like a little bit like, I'm going to leave you before you leave me. And don't do that. That's silly because you're always connected. Once you're in our community, whether it's the larger community, like all of you here today, you're with us for life. We care about you. I care about you and the work that you do and how well you do that with ease. And if you're definitely one of my mastery graduates, you're sharing that license with me. You're mine for life. That's part. It's in writing. That's actually not in writing, but it's implied. So we're getting ready to start our new pod here in just a couple weeks. And just a heads up for those of you who have been on the fence or curious about it, don't be curious for too long because we only enroll once a year. So, let's talk about it and see if it's really the right program for you. Not everybody's allowed in because it needs to be the right program for you. I don't want to drag you through it or to it. And I know you don't want to be dragged. Moreover, I don't want you to waste your time. So if it's not the right fit for you, let's figure that out together. But definitely get those questions asked because it's usually more for you if you've got an inkling for it than it isn't. So if you're even thinking, if your tummy's got a little butterflies right now, just let's talk about it so that you don't have to wait another year. You don't want to be.
Gina, I'm sorry.
Yeah.
I'm finding the link for your schedule. I'll throw that in the chat.
Oh, thanks,
If folks
Sally.
want to chat. Yeah, it's taking me.
Yeah. Perfect. Yep. Get on my calendar and let's just chat. It's not, there's no charge for the call. It's not an obligation, but you just get to get clear because think about it. If you waited a year, if you're like, oh, you know what, this year's not the year. I'm really not ready. And then you wait another year. What does your work life look like 13 months from now if you do nothing different? Right. And some people are saying, well, but I do CEs during the year, Gina. It's not like I'm going to do nothing different. Sure. And are you going to have a system and a method and accountability and community to throttle you to the finish line quicker in the next year if you're just doing CEs here and there? So just some things to think about. I'd love to talk to you if you have an inkling. Welcome to those of you who just came in. I think it's Yeti. I was thinking about your name last week when you were here. Thanks, Lori, for popping that in the chat. Go ahead and grab that link, you guys. You're welcome to my calendar while I have space on it. I think Yeti is your name. You were chatting with us last week. We didn't get to ask you specifically, but I have a friend who spells her name with a J and it's pronounced as if it was a Y. So if I mispronounced your name all training last week, I apologize. And I would love to know the pronunciation of your name. Len, I'm glad that you're here too. Welcome. Alina, I said hello. And Shelly, hey guys, glad that you're here. All right, are you guys ready to talk some functional movement and neuroplasticity and why it's important? You guys ready for that? Okay, I'm ready for it too. And I know you guys have some questions too. Lori sent in a question during the week, so we'll definitely leave some time for Q&A, probably around the halfway mark of our hour together here today. So last Sunday, 2 days ago, 3 days ago, whatever, over the weekend, when I talked, hey, Shelly, you're ready. Okay, let's go. Last time when I talked live, the video, I was just catching up with myself here, guys. Give me a second. Here I come. The live that I did over the weekend on functional movement and neuroplasticity, impromptu. You're welcome to grab that link. If you're on my email list, you have that. If you want to be on the email list, send me a note. I'll send you the link. I talked about functional movement and neuroplasticity, and I started with, we need to know what that is. Before we can talk about what to do with it or how it applies, we kind of need to know, we need to know what it is. That's the same as any part of our anatomy. In order for us to resolve anything anatomically, we need to know what it is that we're working with and how it's designed to work, and then have tools to intervene if something's up or awry. So question for all of you, which I also shared over the weekend, what do you know as the running definition of functional movement? And I ask sincerely because there are some questions about like, well, what actually is that? There's a functional movement course, and there's a functional movement training, and there's a functional movement program. And then am I doing functional movement if I teach movement for a living? So there's some questions about like, what is functional movement? And I have my definition and the way that I utilize it when I work. And it would be helpful for me to talk with you on the same page rather than at you or around you or even worse, confuse you. So what is your running knowledge of functional movement? What do you know it to be? Anybody? Tell me. Maybe you don't know. Maybe you're like, that's a really good question, Gina. I hear the phrase all the time and I don't actually freaking know what it is. That's just fair and honest.
Yeah.
I'm just going to go run out my sheet because, as you know, I started teaching a functional movement class yesterday. So I'm just going to go and run to get what I've penned out, and it'll be interesting to get your feedback.
Okay, perfect. Love it. Go ahead, Lori. While Hannah's getting her page, I love this.
Oh,
Cheryl
reminds
too?
me of like how we move in the world, like how we functionally move in the world. Like I teach it also. Anna and I also teach it. Gina, you teach it. And we teach it like as a yoga teacher and a movement practitioner, I teach it in this little lens. But what I message to my folks, it's like it's bigger. It's how we move outside of the yoga, Pilates, personal training world. It's 99% of how we move in the world.
Yep, great. Yep, Shelley said the same thing in her chat note, activities of daily living. What about you, Cheryl? Oh, can't hear you. I can read your lips though. Darn it. You're gonna try? Okay. I know you have something good to say. Maybe if you can't, try your mic. You usually get that fixed. Anna, and we'll go to Anna. We'll come back to you, Cheryl. Anna, do you have your notes? Do you want to read to us what you're...
I do. So functional movement is a series of movements required to complete the task at hand, whether it's shoveling snow or downward dog.
Great.
The key is to carry out these movements as efficiently as possible. So how do we accomplish this? By using the correct joint action and engaging the primary muscles to support the joint in its function. So using the joints and muscles properly will build strength and agility and avoid discomfort, pain, and injury.
Okay, great. Cheryl, you back yet? Yes, yay.
Just 1 second.
Okay, super close. I hear you.
Yeah. I think I'm coming in.
Okay.
Okay, can you hear me?
We can. Lovely.
Okay. Yeah, when I think of functional movement, I think of, especially with functional exercises, it's movements that we can apply to our everyday living. I've taught like a mindful movement class, and I try to incorporate like push and pull and carry and hinge, and I don't know. So I kind of like, those are the things that we do with our, everyday life when we pick something up or, push something up onto the shelf. So I kind of see like that's how I interpret functional movement.
Yeah. Okay, great. Yep. These are all good, fair, lovely, great definitions for sure. I'm drawing a blank right now. What's the other type of therapy? Not physical therapy, the other type of therapy. Not physical therapy, it's not orthopedic therapy. I'm losing the word right now. The type where they teach you finer tuning movements. I worked for one for a while. Oh gosh, I'm missing the point. I'm missing the word, so I can't land the... Nope, not that one, Carrie. No, good guess. It's not what I'm thinking of.
You said orthopedic, right? I know you did orthopedic.
Occupational, that's what it is. Thank you. Yep, that was the word I was looking for. Yep, all these are great. And that point I was trying to make is on the occupational therapy plane, there's also a large focus on how do I get someone to be able to use the restroom again and pick up a fork and bathe themselves, And so because we're all talking about the definition of functional movement, I want to make sure that we don't start to confuse it for occupational therapy. Not because that's not our lane, but occupational therapy, in my experience, because again, I did work with one for a period of time. My experience with occupational therapy is they're teaching someone how to do something they should be able to do and have limitations around. And that's why it's therapy. And thank God for that, right? Like, amazing. In functional movement, we're working with how the body's designed to move to do that job. And are we moving in that design? Or are we distorting the movement? Are we not using the body the way it's designed? Are we getting the job done? Because the body will do almost anything you ask it to do, even at the risk of causing pain. Shelley, I'm just going to mute you because there's a little bit of background on your end. That was more than I thought. Is the body doing what you're asking it to do, even at the risk of creating a problem? Or is the body working, that's okay, Shelley, or is the body working functionally and it's not creating a drag on the system or creating a setup for any compensatory patterns? And for me, when I'm talking functional movement, that's the specificity around functional movement versus what could be occupational or, an orthopedic intervention, so to speak. And the reason I focus there, it's part of the method, the reason I focus there is because every time I'm working on how the body's designed to do a movement and get out of the way whatever's stopping that from happening, chronic pain goes away and freedom and movement is restored. And so that's one of the main touchstones of the SHOTS method, actually. It's one of 3 touchstones. That main idea right there is what we're up to, like, a third of what we do. And so that distinction matters to me. Does that land for you guys? Do you hear a distinction there between functional movement and what could be occupational therapy intervention? Are you hearing the difference? Are we all on the same page yet? Yes? Perry, what about you? Yeah, thumbs up? Okay, great. So as long as we're all on the same page on that one, that's cool. And Shelley too, perfect. Thanks for using your chat, Shelley. I'm glad you're here and with us. All right, so functional movement, there's that definition. We've got that, which is great. The next topic that I shared over the weekend was neuroplasticity. Big word, fancy word, kind of a crowd pleaser, kind of a ooh. And what does it mean? What does it mean to you guys? Does that mean anything to you? What does neuroplasticity mean to you as a body worker? Whether you're a movement or manual practitioner, you're coming across neuroplasticity. What does it mean to you? Anybody?
I think to me it means, the brain's ability to be rewired.
Okay. Good. Shelley says the capacity for change. Anybody else? Neuroplasticity. Anybody else?
Yeah, it's how it, based off of what Shelley and Anna said, how it's rewired to go from how in movement, how it was moving in one way into another way.
Okay. So you guys are really clear on the change part of neuroplasticity, which I like. Any other part of that definition to add in here? Anything? All right. No, I don't want to talk while you're still thinking. That can feel jarring. Okay. Another part, yes to the change, the capacity to change, to be remolded and altered and, redirected, if you will, first from a mold. So plastic, as in molded plastic. So the brain does take a shape, I guess, pun intended. The brain does take a snapshot. The brain does have a established way of moving, posture, function. It has that snapshotted. And an example that this will probably land right away. When we are first learning, when we're little, how to hold a fork or a toothbrush or a pen, we don't really know how to do that. There's no mold, there's no model up here yet. So we fumble and we figure it out and we're, helped and aided. And sometimes it's messy and clumsy. And then eventually we get it. You're like, boom, every time I pick up a pen, I have a pen in my hand, ready to go, ready to write. There's a mold in my brain, in my nervous system that tells me this is how you do this thing. This is how you do this action. This is how you hold a pen. This is how you hold a toothbrush. This is how you ride a bike. This is how you go up a flight of stairs. There's a mold that's been established after patterning from the nervous system. Synapses wire, they fire, they lay tracks, and then there's this mold made, which is great. It is great because I don't want to have to think about how to hold a pen every time I want to sign my name. Hey, William, nice to see you. I don't want to have to think about how to walk up a flight of stairs every time I'm met with one. There's some movements that I want my body to already have memorized. Do it this way always, and I don't even have to think about it. That's the mold. That's the plastic part of the mold. That's helpful, needed, and thank God for that. Unless we learned how to do one of those things incorrectly or not optimally. And now it's not great that it's sort of locked in. It's not locked though, it's molded. And that's the benefit of the change part that's available to us in neuroplasticity. So it's molded into this plastic mold that says the way you do this thing is the way you always do this thing. Helpful, takes, bandwidth away from me having to think about so many things every day. And that only works if the way I do something over and over and over again is optimal. Because the creation of that mold was because it was done over and over and over again until a synapse is snapped and wired enough to lay down tracks that this is the way. That happened through repetition. So if there's repetition that makes the mold, there's repetition that keeps the mold. And that only works if it's optimal. If it's not optimal, the way you do the thing over and over and over again could become problematic. So we talk about a lot of these things in mastery and our, in the first quarter of mastery, we talk about, well, what are all these patterns that we do all day long and we don't even realize aren't optimal? Because if we don't realize it as practitioners, our clients and students and patients don't realize it because we missed it. And we know the definition of neuroplasticity and functional movement, and we might have missed it, right? So we go over a deep dive into all of that, and it always moves the needle on everything that you do, whether you're a manual or movement practitioner, because you have a body moving in the world. So joint action is joint action is joint action. The way you get into functional movement is by knowing the joint actions, what they are. We've talked about those here a few weeks already. What the muscles are that do those joint actions. Are those muscles doing the joint action? And is that action optimized? If it's not optimized, if the mold has been set, if the clay has been melded, and we need to make a change, how do you do that? How do you do that? How do you change someone's common habits that have been laid down like tracks of memorization where they don't even know they're doing it, let alone doing it incorrectly? How do you change that? It's important. It's important for all of us, whether, again, we're movement or manual practitioners. If you're the movement person in someone's life and you're seeing them move slightly off and not optimized in a joint function while they're with you, they're doing it everywhere. And if they're with you and they're weight bearing, problem. If they're somewhere else not with you weight bearing and you know that, problem, you're complicit. I know it's heavy. I'm just sort of laying that down. And if you're a manual practitioner and you're there to, manually manipulate their tissues that are problemed, that are achy, that are symptomatic, the question always gets to be for manual practitioners, what caused it? What caused it wasn't them laying on your treatment table. It was how they moved or how they didn't move. What caused it was their functional movement or lack thereof. Non-optimized functional movement. You can still get something done. You can get a daily activity done with strain on your joints and no support for your low back or your sacrum, or you could get that same daily activity done where it's actually strengthening for you. And there's ease and grace in that. There was a day when there were cavemen who didn't have a gym and they were stronger than we were. And I brought this up once in a training and someone said, yeah, but they died at the age of 20. Okay, fine. But that wasn't because of their functional movement and their herniated disc and their dependency on medication. That's not why they left, right? They left for other reasons because they didn't have shelter and all kinds of other things. But the functional movement part is unfortunately a huge contributor to why folks are in chronic pain, especially in this country, and it doesn't get resolved. And our responsibility, so I'm enrolling all of you, I hope, into our responsibility as body workers. Our responsibility is to know functional movement, to be responsible to neuroplasticity, and to have a solution when we see something's wrong and bring someone back to an optimized function, the way they were designed, so that they can live pain-free. Us missing something or sort of letting something slide or not knowing the implication of it. Sometimes we don't let it slide because we're being sloppy or, not in service. We don't know. Like we see something's off, but we're not exactly sure what, and we're not really sure what to address or how to do that. When we let that slide, their future hip pain, their future inability to do X, Y, and Z, their future dependency on pain medication is on us. because we saw it and we get to intervene. So that might sound a little heavy, but I really take the work that we do that seriously. You know, when a client comes in, I am all at it. I am all at it. I'm not going to do half-baked. Now, if that's bringing up some fear in you guys and you're like, I don't know if I'm doing it right, don't worry. I mean, that's why you're here, so you can learn more and grow as you go. Definitely don't go backwards in time and being self-beat up about something you didn't know yesterday or last year. When you know better, you do better. And if it has been recently, you can always call that client back and say, hey, you know what? I just learned something new. Would you be willing to come in? Can I have 20 minutes of your time? My gift. I wanted to address something when you were here and I didn't. And now I know what to do for it. Do you have 30 minutes? Are you kidding me? That is the most in service you can be. What's not in service is if you're in that environment and you're in self beat up because you don't know what to do. That's not being in service. That's being up in your own space. You're not even present to the person in front of you. So just be really thoughtful about where you're at and where you want to go with the results that you want to create for your clients. So functional movement and neuroplasticity. How did that land for you guys? Did you get something good from that? I wanted to make it succinct so I can move on to Q&A. Do you guys have any questions on that? Functional movement, optimizing functional movement, neuroplasticity. Any questions before we move on to other cues? Okay, spectacular. All right, so we have a different switching lanes, but it's never really that switching because we're still on anatomy. Lori asked a question, asked that we address something this week on the dorsal side of the foot or the top of the foot. Let me grab Murph's foot off the floor. Okay, so dorsal side of the foot. Lori, what's your question? What's your question in total? So we can all be on the same page.
Yeah, so I have a friend / client that's got pain on the top of his foot. And I realized that like he told me this a week ago and I didn't get back with him because I'm like, I don't know what the fuck to do. So what I did, yeah, right. So yesterday I was like, you know what? I haven't forgotten about you and I don't know what to do. So let me go find out.
Great.
So, yeah. So it's just a reminder that like if you don't know, just say you don't know, but I'll find out instead of a week later, like say a couple, when you realize that you don't know.
Yes. Can we just pause there? Yeah, I'm super celebrating you, Lori, like amazing. And can we just pause there for a second? Because I really want to make sure we all heard that.
Yeah.
You are not required to have all the answers when your clients come in, but responsible to get them. And that might be while that client is still in your care and you're going to call them again next week, or like I just said, phone someone from a week ago, or required to get them in your lifetime.
Yeah.
Doesn't have to be with that particular client, but if they bring a question to you or a problem to you or a functional discrepancy to you and you don't have the ability to solve it, it won't be the last one.
Mm-hmm.
So be responsible to go figure it out.
Mm-hmm.
And then you've done your role. See, I really believe that clients come to us at the perfect time.
Mm-hmm.
They either know you have an answer for them that you might not be admitting that you have an answer. They might be slightly ahead of where your skill set is in this moment because they know you're striving and that's still the perfect time for you. Or they may bring you something that's been a blind spot for you.
Yeah.
Like in this case with your client, we're like, I don't freaking know. I literally don't know. Like I see it and I don't see it. I have no idea. Which means that they're encouraging you with your responsibility and your vision to keep going, to go find out, to go back to your community, to ask your mentor, to dig in your notes, to apply what you learned on paper that didn't make sense until now it's in real life. Like they're there to perfectly timed for you to be at your next cut, for sure. It's really not that a client comes to you with something that you're not ready for, that you shouldn't be dealing with, that is out of your lane. When it's not in your lane, that's your lane to say, this is not my lane. And here's who else to go to. We talked about that in Tuesday training weeks ago about partnering. You get to have a network of people who do things you don't do, like physical therapists, heart surgeons, plumbers. Like there's people in the world that do things I don't do. Doesn't mean I'm inept. It means I get to partner with somebody else to get the job done. So even when a client brings you something that's not in your lane, they came to you for a reason because they knew you'd have the answer. Doesn't mean you have the way to resolve it for them, but you have the answer on who to go to. That's still the answer. You're heading them quicker towards the solution, even if it's not you physically doing the work. So be really thoughtful about that. Couple ways I see practitioners take, especially elite practitioners, like the folks that I train in the mastery track, they're really like elite status. They want to do it all and do it best. And I'm here for that. And there's still some things that are not in our lane. So rather than being self-beat up about how I'm not the best, that's not true. That's not true. You have an answer for someone that's helpful. And then the other end of the spectrum that I often see is, well, I can't do this and I can't do that. So, it must be that I shouldn't keep going. And that's also just not true. It just means that you get to learn more. If there's something that keeps stumping you, then get some training about it. If you're noticing that people are moving in a way, this is how functional movement came to me, by the way. Cheryl's like, yes, I'm noticing that. So I wasn't even working with a couple clients as a movement practitioner. I was strictly doing manual work, hunched over a table, doing amazing stuff, working hard, diligently, smartly, blah, blah, blah. Right after I got done doing all that work, woe is me, they'd stand up and walk over to get their shoes on and bend down to put their shoes on. I'm like, you've got to be kidding me. They literally just undid everything I just slaved over the table for an hour. What the hell? And so it's our responsibility to know functional movement and what to do about it, even when you're a manual practitioner. And that's how I started adding it in. I was like, oh, that's how they're uncomfortable every week. They feel great now until the 8th time they go put their shoes on that way. Now they're not going to feel so good. And then that started calculating, oh yeah, and that's actually when they call me back, like 10 days later for their next session. Okay, this is Groundhog's Day. This isn't working. So functional movement's a big deal. If you don't know it yet, that's okay. Maybe you're a movement person and you're like, I know movement, but I don't know how to correct movement. I don't know what to do when someone has orthopedic limitations. Okay, so great. There's your next cut. Perfect. Like, we got you. No problem. All right, so back to the top of the foot. I do find my way back. It sometimes just takes me a minute. Back to the top of the foot. So your client has pain on the top of their foot, and Lori, and what we know about pain is that, will you tell me, what do we know about pain? What do we know about pain? High level, what do we know about pain? Unmute, Laura, unmute.
It's generally referred from somewhere else. It's, the body's designed not to be in pain. So if there is pain, I usually think that there's a misalignment.
Yeah, it ran out of ways to get rid of it.
Ran out of ways to get rid of it. Yeah.
And what's happening when it's getting rid of it? The body's not happy being in pain, and it's going to morph to get out of pain. What is that morphing?
It usually compensates somewhere else. Yeah, my friend, he was like, it's which now that we're talking about it, he's like, I feel a little better this week. And I was like, I mean, I'm glad you feel better, but I'm like, oh shit.
Where else did it go?
Yeah, where else did it go?
Right.
Yeah.
So that high level sort of checklist, I know some of you do like checklists, and I always say there isn't one, but that high level sort of checkpoint, that's a better way to say it, checkpoint is, okay, I have very specific pain in a very specific part of my body. I hear you, client. I believe you. And in your mind, you're like, there's only a 10 to 20% chance it's actually there. Okay, you got to know that. Otherwise, you could spend the whole session digging at their foot, moving their foot, stretching their foot. I don't know, pulsing there, like whatever you're doing. You could be at the foot. It's only a 10 to 20% chance you're going to resolve it there. So know that going in. Do you get to address the pain in the foot? Yeah, but it's not caused by something in the foot most of the time.
Yeah.
And then you said something really important. The body doesn't like to be in pain, so it will morph, AKA compensate, to get away from pain. So 2 things about that. If the pain's persistent, the body ran out of back doors, ran out of ways to morph. And so now it's a problem. And in all the other ways that it did morph, every one of those is a compensatory pattern. And your responsibility, if you're correcting function and eliminating pain is to trace those compensation patterns.
Mm-hmm.
You got to know how to find them, and you got to know what they do, and you got to know how to intervene.
Mm-hmm.
And so that might be where you're at with your training. That's cool. We do that, of course, with our method. So Lori, based on that, where do you think, and it's tough to do, right? Where client's not in the room with us. I'm not there. I can't see.
Right. I've already kind of, I'm like, oh, I think I know where it went.
Great.
And, yeah.
Great. Where do you think? Where do you
Well,
think
I
it is?
looked at the muscles of the top of the foot. I'm like, okay,
Good.
I believe that it is. Let me just look real quick here. Extensor digitorum longus.
Okay. Why do you think it's that one?
Because of where, let me just look here. I think it's that one, where he was pointing to. He pointed to that specific area, and the muscle goes down there.
What area did he point to?
The very top of, yep, okay, outside, yep, down towards the toes a little bit, not that far. Yeah, and then lateral. Yeah, like over in there.
Okay.
And I'm just looking at my book. And then hold on, or could it be? Yes. So that's what I narrowed it down to.
Okay. Why that muscle?
Is that it? 3, 2. I'm looking here.
Okay. Why that muscle? Why did you pick that muscle?
Because he has pain when he walks.
Okay.
Dorsiflex.
He has pain in dorsiflexion when he walks.
Yes.
Okay. So now we're on to functional movement again.
Yeah. Interesting. You said that part. That was part of the main injury in that area that stopped me from dancing. When I stopped dancing, I've been seeing an osteopath for the last couple of years, and she worked on my alignment of the body, where realign the body. So when I treat people now, I check the whole alignment of the body. Sometimes it's the whole body that's shifted to the left or shifted to the right or it's twisted up. So when I look to correct the alignment, that's when it might solve that problem.
That's exactly what we do too. There's so much overlap in osteo and the shots method.
I know, yeah.
Agreed. Yeah. And it's funny you said that, Perry, because as I was thinking, I'm like, okay, that's the muscle that I'm seeing. But then I also know that he moves with, there's no 4 curves of the spine, there's a pelvic tilt, there's like there's more structurally going on to your
exactly. Yeah. And my osteopath gets on me like, you walk in parallel. You know, people tend to walk in duck walking. Unless you're a dancer, there's no excuse for that. So
even as a dancer, even less so, because you've already been doing it while you're dancing. You need to not do 10 and 2 anymore. Toes forward is neutral at the hip joint. So yes, exactly. Okay, so back to, rather than pointing at a muscle, this is where the pain is, so this must be the muscle. It's the same idea as the 80-20 rule.
Right.
There's only a 10 to 20% chance that this is the muscle that's the problem, but this is the muscle that's giving him sensation. And then you set it while he walks. So then you get to start looking at, how is he walking? And what are the steps of walking? We know in our method, there's 12 different steps of gait, and each one of them has functional, requirements. It's one of the patternings that we do that I was just mentioning. So what is happening in his gait that should be happening and isn't, and why isn't it happening? It's not because this muscle's got a problem. Muscles don't spontaneously have a problem. Then you start looking at the columns as they hit the ground and the connection that those columns have to the keystone. Yeah. So, and I'm going kind of fast here, and I know
it's okay, because that's where I went to. I think in my head, though, I just needed to kind of look at I didn't even necessarily know the muscles of the foot that, that do dorsiflexion. So in my head, I'm like, okay, I go there, but then what do I know that about his frame, about his structure, about how he moves, going up the food chain?
And did you measure him too? Did you do our measurements?
I did. Yeah, I did it a few weeks ago with him. Yeah, I don't think I have him right now, but yeah.
No, yeah, don't tell us what the measurements are, but he had measurements and discrepancies in his pelvis and sacrum?
For sure.
Okay.
Yeah.
So how does the discrepancy in his pelvis and sacrum affect how his legs hit the ground? How does the discrepancy here affect how his legs hit the ground?
Well, it's not gonna be, he's not moving optimally.
Right. And so your job in the treatment setting with him is what specifically is happening in his body when his legs hit the ground.
Oh, I see. I got it.
Because that's what's causing that muscle to spontaneously combust.
Yeah,
if it wasn't an imbalance in his sacrum and the way his columns were hitting the floor, both feet would have a similar symptom, but they don't. Right? So that's the other thing to look for. What if your client said, gosh, the top of my foot, it's like the arch on the top of my foot is just so sore, I could barely move. Is it both feet? Yeah, it's across both feet. And you might think, oh my God, this is probably a really complex issue. How do you know it's not their shoes? It's both sides. Discrepancies and compensatory patterns are typically unilateral. If you have the exact same symptom on the same part of the body on both sides of the feet, that's equal.
Would you say discrepancies and what? And are unilateral? Discrepancies and did somebody hear it?
No. What did I say, Anna?
Yeah, discrepancies and compensatory patterns.
Compensatory, probably. Yeah, got it. Thanks, Anna. I knew somebody else had it.
Okay, so those are typically unilateral. That's why we drew diagonals. For those of you, Lori and Anna, you know that. Cheryl, you're going to get that this year, right? So it's not symmetrical. If it was symmetrical, it wouldn't be a problem. Typically what happens when we get into orthopedic or therapeutic or osteo discrepancies, anything in that sort of category, the reason we have a problem is because we have a flat tire on the bus or we're driving without a headlight. It's one thing that's off. We're lopsided. We can't stand on this foot, so our spine laterally flexes to the opposite, and then our head tips to be parallel with the horizon. And that's how you trace it. So again, if your client says, oh my gosh, it's the same toe on both feet. Did you get new shoes? I did. And the toe box is really small. Okay, well, you don't need to panic about their sacrum and pelvis being out of alignment. Their shoes don't fit, right? But if it's only one and it's one spot and it never shifts and it's only one and it's only one, that's because all of those compensation patterns that I just drew in my body landed somewhere and there's nowhere else to go. The body's like, I don't have any more options. What the heck happened here?
So I gotta go back and look at his measurements.
You could spend so much time on his foot and never get him out of pain. You'd get his foot to be more comfortable for today, but what caused his foot to be uncomfortable is still the way he functions, and that will persist, and then the clock will tick, and at some point in the future, he'll have that pain again, but it won't be as bad this time. It'll be like a 7 or 8 instead of a 9 or 10. And you'll be like, what else do I do for his foot? It's not in his foot.
Right. I knew it wasn't in his foot, but I didn't. I'm like, okay, now that the minute we started talking about it, I'm like, oh, I can see where it could be. Yeah. So thanks. The clarity. Thank you.
So look at his function and how he's doing that activity that rears the dragon's head. Rears the dragon's head? That raises the dragon's head. And then look at his measurements and see how his columns are hitting the ground and all of the ways that those compensation patterns showed up, because you get to navigate them. Here's why. We talked about this at the beginning. A compensation pattern, depending on how long it's been happening, is now a new pattern. It's a molded plastic. This is the way we do the thing. If you don't undo that neuroplastic pattern, even when you align them, they'll use their body the old way on the new alignment and muscles move bone. Now they're back out of alignment again.
Yeah.
It's got to be both. That's why that's our other touchstone. So that's why you do the alignment and you do the repatterning. You have to do both.
Yep.
Okay, you got it, Lori?
Got it.
Yay. Okay, let us know how that
I have a question.
Yeah,
Go
I know I'm like, yeah, got it on it.
Good. Anna?
So while we're on the foot,
Yep.
do you have the ability or time, I guess, to address the question relating to the foot?
Sure.
So you've mentioned it, I think, several times in Tuesday trainings, and I keep going to bed thinking about it, and I can't figure it out. So I'm going to ask, and that is that plantar fasciitis is somehow tied to the pelvic floor.
Mm-hmm. Directly.
And
You know this, Anna. We talked about this in training, but that's okay. We'll give it to you again. See, sometimes we just get to review. As soon as we review, though, I bet you're going to be like, oh, I had a V8. I knew that. I never used to drink V8, but here we go. You ready? It's super.
I am, because I'm thinking tibialis posterior, and then I can't.
No,
Okay.
not tib posterior. So what are the two muscles that make up the arch on the bottom of the foot?
Well, looking at my anatomy book, the peroneus longus goes underneath, and then the tibialis posterior.
Anterior, tib anterior.
Tib anterior.
Mm-hmm. So those are the two muscles that make up the stirrup on the bottom of the foot. There's lots of muscles on the bottom of the foot. We're talking about these two right now because we're talking plantar fasciitis. Okay. Do you remember when we said, I think it was last week, when we said, and I don't know if it was here or if it was in mastery training. I know I said it somewhere last week.
I think it was last week because, again, at Tuesday training. Yeah.
Okay. About itis, that when
inflammation. Yeah.
Itis is inflammation. It's when things are rubbing that shouldn't be rubbing.
Yeah.
Okay. And so when we focus on, for example, plantar fasciitis by putting, electrical stim or a tennis ball or cold packs, that's cool because this is where the rubbing is and this is where the irritation is, but this isn't where it's being caused, right? Like we talked about carpal tunnel. It's not from the wrist. Okay. So then the question.
Pause just real quick. I'm sorry about the itis. So would that lead to like constant rubbing? Would that lead to degenerative, or is degenerative? It could.
The rubbing doesn't lead to degenerative, but the itis does, because when there's inflammation in a joint, which is typically where it is, where two bones are rubbing, whenever there's inflammation present, that's acidic. And the longer that those tissues are held in an acidic environment, they degrade.
Got it.
Which is why some of the treatment for inflammation is to just quell the inflammation. And what I'm appealing to you guys is that that's not the solution. That quells the inflammation, but it doesn't solve how it started. Okay. That's still present in the body. That function, that rubbing, that misalignment is still present. Okay. And you do get to get the inflammation to go away because it can degrade over time.
Got it. Okay, cool. Thanks for the
segue. Okay. So Anna, back to peroneus longus. Peroneus longus, we know, goes from the fibula down the side of the leg, behind the malleoli, and up underneath the foot. Okay, cool. That attachment point here at the top of the fibula, what else attaches there?
Hamstring.
One of the hamstrings. And that trail goes from top of the fibula all the way up the back of the femur. And where does it stop?
The hamstring?
Yeah.
Sit bone.
Sit bone. Now we're in the pelvis. And look at you knowing your muscles, baby. I love it. Yeah, baby. So now we're up in the sit bone. And what muscles attach here?
Lots of them.
Lots of them that start to go.
A lot of the rotators attach.
Yep. And a lot of the muscles inside the pelvis.
Yeah.
And a lot of intrinsic muscles attach here too.
Oh, that's your pelvic floor.
That's the trail. And if you look and do this, you guys, check this. If you watch people who outwardly acknowledge that they have plantar fasciitis, again, it's typically in one foot, not both. There's another clue.
Yep.
Typically in one foot, not both. So that's a misalignment. And we know from the lever system masterclass that we did earlier this spring, when there's a misalignment, muscles can't get stronger. They can only get strong to a certain point. They can't fully function if the bones that they attach to aren't aligned. They can't fully contract. The spindles can't overlay in that way. So plantar fasciitis symptoms are typically unilateral. That's a misalignment. So they can't get stronger. We know that from our lever system masterclass. And if you look at folks and the way they move who have confessed plantar fasciitis symptoms, notice I said symptoms because it's not a permanent, it's not a diagnosis, it's a symptom. As soon as you give someone that diagnosis, though, they're like, it's fixed, it's in my foot's the problem. No, don't do that. It's a symptom of something. It's not it is a diagnosis, but it's a symptom of something. As soon as you watch folks who have, admitted plantar fasciitis symptoms and you watch them walk, they're not using their core, and or their pelvic girdle is wildly out of alignment, which means the muscles in this area can't get strong. We know that from the lever system masterclass. Right? So they tell you the symptom and you look at them and you're like, I could have guessed. Huh, look at that. The trick on that particular diagnosis, though, is they are positive that it's in their foot.
Yeah.
And because it requires a ton of intrinsic strength after they're aligned to remedy, if they lost that much intrinsic strength to get them to that symptom, it's an interesting enrollment to get them on board with you to do intrinsic work, to engage.
So I have a client, and we've actually, well, I haven't worked on the plantar fasciitis directly because of everything we've talked about, but this client will tell you that he has incredible intrinsic core, incredible core strength. And by the way, I'm not even going to finish this sentence because I know I came to our summit conference thinking that I had in fact, saying to you, I've got incredible core strength, and you saying to me, yeah, you don't. Yes, I'm not even finishing it. Okay.
Okay, so instead of just being right or wrong between your client, which I get, it's so cute between you and me, but how did I show you, Anna? Instead of just being more right than you, because we don't want to do, clients aren't going to be enrolled in what we have to say next if you're just like arm wrestling them about who's right and who's wrong, right?
Yeah.
But I showed you in your body so that it didn't have to be from me. Your body showed you. How did that happen?
You put me in optimal standing, and I couldn't actually be in optimal standing because I, my pubic bone. I'm laughing because
I love that you're cracking up about your pubic bone of all things.
Because
I forgot. I know
all of these folks. I mean, it's
anatomy.
the first time I'm meeting Gina live. I booked a private with her in Cleveland before the summit starts, and I walk in. We've never met live, and she looks at me and how I'm standing, and she says, yeah, it's a little too early for you to have your pubic bone this close to me. Just move that puppy right back. So
there was just,
I was standing literally with, with my pubic bone way ahead of.
I learned.
Yeah.
It was just this, so again, it was this alignment or lack thereof, right? It was a misalignment, non-optimal alignment in this area of the body, which meant you couldn't engage all the muscles that you had available to you. Yeah. And then when I measured you with another one of our shots method measurements, you were like, oh my God, I'm a willow tree. Right. Yeah. So all you get to do is just neutralize someone's alignment and do that 4-finger test that we did in person together. And when he feels like a willow tree, you just say, oh, well, there's more available for you. Instead of, you don't have any core strength, you're out of your mind. Like, you'd never say that, Anna, but rather than being right and wrong with your client, just say, okay, well, there's much more for you because I shouldn't be able to take you out with 4 finger pads. And then the math just sort of works. And they're like, yeah, you're right. And then I'll say something like, what happens if the wind blows? Are you okay out there? And they're like, yeah, I'm not actually. Okay, great. You want to do some work on that? And that's when we get into our intrinsic work. And that's actually, interestingly enough, that's our 3rd touchstone of the method. So thanks for bringing that up, Anna. We got all 3 touchstones in here today. That's so good.
Yeah.
That's so good.
Yeah, I had forgotten about I knew I was willowy, but I'd forgotten that you literally just touched me. And
right. And when we're
thank you
standing
for
in
that
optimal,
reminder.
yeah,
Thank
you're
you.
welcome.
And
Yeah, you're
also
welcome.
not making him wrong, not
Yeah.
saying, oh, well, you know, not that I would ever say you may think you have intrinsic core strength, but I wouldn't quite be as eloquent as you were with me.
Well, that's okay. Just, I mean, you want to be though, right? Like think about your
Yeah.
vision for the clients that you're serving. If your
Yeah.
vision is for them to actually be strong, then you won't really feel like gloating about how weak they are. Not that you are. I'm saying that like you won't have to worry about the language that you choose if what you really want for them is for them to be solid, grounded, secure, strong, able. If I really want that for you, I'm not going to gloat about how you're not there right now. I'm going to like get to that vision and hold that for you.
Yeah.
So great. You think you're strong? Awesome. How about more?
How about more?
How about more?
Really good.
Right? Let's keep going. You have more available in you than, you know, there's more in you than what you've been experiencing right now. And look what that could get you. Let's go to there.
Thank you.
Yeah, you're welcome. Of course. You're doing great work out there too, Anna. Okay, so that was a fast hour. That's about all we have time for today. Yeah, Harry and Shelly, that was good. I'm so glad you guys were here. Thank you so much for participating. I'm glad did you guys get value? Did you get good value? I just said it was fast, but did you get some good takeaways from today? Feeling like you got some good knowledge to work with? Okay, good. That matters to me to be in service to you. So that you are out there doing amazing work with the people that you serve. They're lucky to have you. Thank you so much for being here each week and giving me purpose as well. You always get great value, Shelly. Oh, good. Thank you for sharing that. And I'm looking forward to seeing you guys again next week. So thank you for being here. And again, grab that link to my calendar if you want to talk between now and when I see you next.